and welcome to Lecture 4. In this video we are going to look at the embryological development of the heart and also what happens when it goes wrong. We will look at some of the congenital abnormalities resulting from the disruptions of the pathways and how these might present in a newborn, with particular reference to cyanotic and acyanotic heart malformations. By the end of this video and after any further study, you should be able to describe the migration of the progenitor heart cells from the epiblast to the lateral plate mesoderm, describe the locations of the primary and secondary heart fields, and know which structures develop from these regions. Explain the consequences of disruption of the heart fields. Appreciate the laterality is established early, and explain the result of disruption of the heart laterality pathways. Explain the basic pattern of heart looping, and explain the possible causes of congenital heart disease, and classify common and or serious heart defects as acyanotic or cyanotic, and understand how these symptoms and signs that result from these defects. So let's look at the development of the heart from the very beginning. The heart arises from a group of cells known as progenitor heart cells. These cells arise from the epiblast layer of the bilaminar disc. So right from the beginning, these progenitor heart cells have been mapped before gastrulation. During gastrulation, the progenitor heart cells have migrated towards and through the primitive streak and end their journey at the lateral plate mesoderm between stays 16 and 18. This image on the right is a transverse section of an embryo. The dorsum is up here, and the ventral is down here. Within the ectoderm we can see the amniotic sac, and within the endoderm we can see the yolk sac. We can also see the notochord process, and we can see within the ectoderm the beginnings of neurulation. Sandwiched between the two ectoderm and endoderm layers, we can see the development of the mesoderm. These are becoming more organised and have formed in three blobs, for want of a better word. Most medially, we can see the paraxial mesoderm, followed by laterally the intermediate and the very lateral plate mesoderm on the outsides. The progenitor heart cells are migrating towards the lateral plate mesoderm. As discussed in the previous lecture, the process of this migration is through the primitive streak. The process of laterality is also taking place, so we are developing a left and right axis. As the heart cells are migrating to the lateral plate mesoderm, they form a primary heart field, which essentially means after migration they accumulate on the lateral plate mesoderm and form a hotspot of heart development activity. This hotspot is known as the primary heart field, and this is what will give rise to most of the atria. Most of the right ventricle, and the entirety of the left ventricle. Once these progenitor heart cells have reached the lateral plate mesoderm, they begin to differentiate further and form a cardiogenic region. As the name suggests, cardiogenic is where the formation of the heart begins. But how does this happen? Well, the progenitor heart cells are encouraged to differentiate by the nearby endoderm to form myoblasts. On the first image on the right, we can see the labels for the angiogenic cell clusters. The local endoderm is acting on the heart cells and encouraging them to differentiate into myoblasts, which are going to contribute to the angiogenic cell clusters, which demonstrates that these group of cells have the capacity to go on and make vessels. Once the formation of these myoblasts, the signalling cascade can begin. Bone morphogenic proteins are upregulated, and the WNTs, which are normally inhibitory molecules, are inhibited by local acting endoderm. These WNT proteins act like brakes in a car to prevent acceleration until the right time. What the endoderm is doing is putting a wooden block under the brakes of the car by inhibiting the WNTs, because the endoderm is encouraging the development of the heart now, so it has effectively turned them off, allowing the formation of the heart to begin. So the expression of BMPs and the turning off the brakes, or the WNTs, allow the expression of NKX2, which is the master gene for heart development. As a result of this, the primary heart field is able to develop into endocardial tube, which is surrounded by myoblasts, which is then called the cardiogenic region. If we look at image B, we can see the formation of the two endocardial tubes. At this time, the embryo is undergoing lateral body wall folding under the strain and the growth of the amniotic cavity. As a result of this, those endocardial tubes, each with their surrounding myoblasts, are going to be pushed forwards and towards the midline, where eventually they will meet. The resulting product is two endocardial tubes that fuse together anterior to the gut tube. The endocardial tube is surrounded by myocardial cells. If you look a little more closely at image C, we can see that this has happened. It is surrounded by myocardial cells that have begun to secrete cardiac jelly in the space between the myocardial cells and the endocardial tube. This cardiac jelly is a specialized extracellular matrix which is important in the septation of the heart. So now that we have moved from the primary heart field into an endocardial tube with surrounding cardiac jelly and the myocardial cells, but that's not the end of the journey, because what is happening more cranially, not visible on this picture because we're looking transversely, is the development of the secondary heart field. On this sketch of the embryo here, we can see in red the location of the primary heart field, but more cranially to that we have the development of the secondary heart field, which is what we'll talk about now. The secondary heart field is regulated by neural crest cells. So if we just recap the formation of neural crest cells, we know that the neural crest cells are derived from the ectoderm as the neural fold elevates from the neural plate and meets in the midline to form the neural tube. When this neural tube pinches off, some of those cells on the lateral edge of the neural plate also pinch off. These are the neural crest cells, and they continue to migrate around the developing embryo and give rise to numerous structures. The ones we are interested in today are the secondary heart field and the septation of the aorta and the pulmonary trunk. As the neural crest cells migrate, they proliferate and differentiate until they reach the secondary heart field, where they encourage the secondary heart field to lengthen and the outflow tract, and also form the missing part of the right ventricle. So if we have disruption of those neural crest cells, which we will look at in a few other developmental lectures, we will see how the disruption of the secondary heart field can lead to problems with the outflow tract, which is what we'll look at towards the end of this lecture. For now, let's look at what we have developed so far, assuming no disruption has taken place. Once the endocardial tube has formed from the primary heart field and the neural crest cells have encouraged the lengthening of the outflow tract and the remaining right ventricle from the secondary heart field, these two tubes are able to meet and form a single heart tube. Just before days 23 to 28, the heart tube is going to dilate. This occurs just before a process called cardiac looping. But before we get into that, let's break down the image on the right. The caudal region is formed into a sinus venosus and the primitive atrium. As we move more cranially, we can see the development of the ventricle. Moving further cranially, we can see the outflow tract, also known as the bulbus cordis. The bulbus cordis, or the outflow tract, is made up of caudal conus arteriosus and a cranial truncus arteriosus. And now we know that the outflow tract is made up from the migration, proliferation and differentiation of those neural crest cells. So what about cardiac looping? Well, cardiac looping is difficult to visualise on a 2D screen, so I've included a 3D animation on Minerva for you to see, a more comprehensive view of what it looks like. But in the meantime, let's just have a look here, and you can view the animation afterwards. Essentially, what happens is the bulbous cordis, or the outflow tract, moves more caudally and displaces the primitive ventricle and the primitive atria. This happens between days 23 to 28, and the outcome of which will result in atria forming the superior chambers and ventricles forming the inferior chambers. We also looked at PIT-X2 in gastrulation. We think this is the expression of this on the left-hand side is what leads to cardiac looping. We also know that the master gene for cardiac development is the NKX2.5. This upregulates other factors known as hand 1 and hand 2, which are restricted to the left and right sides respectively, and these are expressed at different times, which allows for different formations of the left and right sides of the heart. In embryology, timing and concentration and the location as signalling factors is very important, and this is what helps us particularly with establishing laterality. So establishing laterality is something we spoke about during gastrulation. But obviously when looking at the development of the heart, these things become very significant. And when we don't get it right, there is significant disruption in the laterality pathways. We can expect significant malformations. So laterality is determined during gastrulation, and cellular mapping or fate mapping has already been determined during the process of gastrulation. Which cells are going to contribute to which side of the heart. And we think that serotonin or 5-HT is a key player in determining what is the left side, because it is concentrated on the left side of the primitive streak. We also think that PIT-X2 is a gene that contributes to leftness, as this is also expressed heavily on the left side of the primitive streak. If we have a disruption of the laterality pathways, we have seen that we produce conditions such as dextrocardia, but it doesn't stop there, because playing around or disrupting the laterality can have a knock-on effect of other structures, such as the septa between the chambers, resulting in septal defects. It can also affect the outflow tracts, isomerisms, or inversions of the whole heart. And in fact, medications such as a group of antidepressants called SSRIs, or selective serotonin reuptake inhibitors, can have a significant effect on laterality, as we know that serotonin is a key player in the process of lateralization. So therapeutic drugs of this nature have to be carefully prescribed during pregnancy, and the cost versus benefits have to be addressed thoroughly. Additionally, retinoic acid has also been linked to developing heart defects, so careful considerations must be made in the prescribing of isoretinoins to females of childbearing age. In particular, retinoic acid has been linked to defects in the most caudal structures, which we know will go on to produce the atria after cardiac looping. So congenital heart defects are quite common in terms of the varieties and congenital defects that we see. As in a lot of scenarios, due to advancements in medicine technologies, there will be more frequently seen in clinic as you progress throughout your careers. Many years ago, you would not likely have seen these pop up as frequently in adults as we see them now, and that's purely because our ability to correct or manage these defects was less effective then, whereas it is more effective now. So the chances of individuals surviving long enough for adulthood were quite low. Here are a few relatively common heart defects. But what can cause them? Well, there's quite a range of causative factors. We know that excessive alcohol intake during pregnancy can cause them, as can maternal diabetes. We know that they can be influenced by genes, and they may be syndromic or non-syndromic. Drugs such as SSRIs we know create laterality defects, as can infectious teratogens such as rubella. We can also see a disruption of neural crest cells in the development of migration and differentiation can cause congenital heart defects. But largely, and unfortunately, a cause of congenital heart defects are often unknown. How can we classify some of these congenital heart defects? Well, in short, they can fit into 3 broad groups. The one that is probably most known or talked about are the ones that fit in the groups referred to as hole in the heart. So these will cover a wide range of defects, but essentially they are the ones where there is an opening between chambers where there shouldn't be one. This could be an atrial septal defect, a ventricular septal defect, for which it could be muscular or membranous, or a patent foramen ovale. These allow for blood flow between chambers where there shouldn't be blood flow, and they can be quite variable in their clinical presentations. Some of these may go unnoticed for a whole lifetime, and in fact we see a handful of patent foramen ovale and other atrial septal defects that come into the DR with no mention of their medical notes. Therefore, we could assume that the clinical effects were quite minor. The second group we can collect them into is those with valve abnormalities. These could be those with valve stenosis, where they don't function correctly, or they could be atresia, where they are slightly too small and fail to shut correctly. And lastly, we have laterality defects and the outflow tract abnormalities. These include a common outflow tract, such as those with common truncus arteriosus, and where there has been failure to septate between the aorta and the pulmonary trunk, or the transposition of the great vessels, where we have the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle, leading to pulmonary hypertension amongst other clinical complications. All of these broad groups can be further classified into cyanotic and acyanotic defects, and this will depend on the clinical correlations and whether or not each defect has influence on the blood oxygen saturations of the patient. In a cyanotic patient, we see them characteristically with lower blood oxygen saturations. We might see young patients in particular with a blue tinge to their lips. This results from defects which allow reduced pulmonary blood flow, and if there is considerable mixing of oxygenated and deoxygenated blood, bringing the overall percentage of oxygenated blood down. This means that deoxygenated blood has shifted into the systemic circulation. Contrary to that, we have acyanotic heart defects. This happens as a result of a net blood flow from the left or systemic circulation being pumped back into the pulmonary circuit. We wouldn't see a decrease in the blood oxygenation saturation, but eventually we would see other effects, as this will have a knock-on effect on the pulmonary circulation, and there will be a presence of pulmonary hypertension and damage to the vasculature within the pulmonary system. So what we are going to do now is have a look at some congenital heart defects and determine whether they will likely be cyanotic or acyanotic. And in some circumstances, we'll discuss the treatment options or prognosis that they might have. First of all, I want you to take a look at the defects on this slide and the following slide and see if you can work out whether they would result in acyanotic or cyanotic defects. Pause the video and scribble down some thoughts while we go through them in the next few minutes. And this is the second group. Again, pause the video and consider whether they would result in cyanosis or acyanosis. Welcome back. Let's collate some of those examples into acyanotic and cyanotic groups, beginning with the acyanotic. Let's look at atrial septal defects. So this is normally present in the septum secundum, and if we think back to earlier in medicine, the first hole present in the septum premium and the second hole, as the name suggests, in the septum secundum. Holes high in the septum, or the foramen secundum, tend to present a little later in life and may be missed in infancy. This is because the individual experiences heart failure or pulmonary hypertension, and atrial arrhythmias due to the excessive strain put on the atria throughout life. Low septal defects towards the inferior aspect of the atrial septum are associated with atrioventricular anomalies, which present as heart failure in infancy and early childhood. Because all of these things allow for left to right movement of blood, because the left side of the heart is capable of producing high pressure, we are going to see a shunt from left to right and result in acyanosis. With regards to ventricular septal defect, it could be muscular. These are less problematic than membranous, as muscular septal defects may correct over time as the heart continues to grow. Unfortunately, if membranous part of the ventricle septum fails to grow, it won't be able to correct itself, and so intervention would be needed to correct this defect. This is normally corrected surgically with a graft of pericardium placed over the hole to close the membranous defect. And again, these are acyanotic because we have a left to right shunt. If we have a patent ductus arteriosus, we have greater pressure in the aorta than in the pulmonary trunk, so blood destined for the systemic circulation is forced into the patent ductus arteriosus, and it makes its way through the pulmonary system again. The symptoms and signs may be highly variable depending on the severity of the patent ductus arteriosus. It might simply be failure to thrive for the infancy, for which the symptoms reside as the infant develops, or it might be that large that a patent ductus arteriosus results in weight loss and difficulty with feeding because of breathlessness, eventually leading into heart failure. So cyanotic congenital heart defects are those which result in decreased O2 saturation. Here we have an example of tetralogy of Fallot, which is an accumulation of 4 defects. The first is a membranous ventricular septal defect. We also have pulmonary stenosis, visible by the narrowing of the pulmonary trunk. Because of that left to right shunt and then the narrowing of the pulmonary trunk, we have an enlarged right ventricle. We can also see an overriding aorta, so the aorta is over the ventricular shunt instead of coming from the left ventricle. This means that there will be considerable mixing of blood, as during ventricular contraction, the hypertrophic right ventricle and narrowing of the pulmonary trunk will encourage the deoxygenated blood into the systemic circulation. This will result in a cyanotic patient. This is an example of hyperplastic left heart syndrome. This is where the left ventricle and sometimes the left atria haven't formed correctly. An infant can only survive if there is a patent ductus arteriosus and a patent foramen ovale. This is because it allows for mixing of the blood to get into the systemic circuit. A little bit of oxygen getting through by mixing is better than no oxygen getting through at all. This is normally seen a few days after birth, as the ductus arteriosus and the foramen ovale close. The left heart does not have the pressure to send oxygenated blood through the systemic circulation, so we see things like blue lips in the infant, as well as fairly sudden decline in the failure to thrive. One way in which we can buy time until the infant is strong enough to survive the surgery would be to induce a patent ductus arteriosus through the use of prostaglandins, or potentially a shunt, depending on the degree of closure the ductus arteriosus has already undergone. Now let's have a look at some anomalies of the outflow tract. The first one to look at is the transposition of the great vessels. We know cyanosis will develop in the first few hours because we have oxygenated blood making its way to its lungs, and deoxygenated blood making its way around the systemic circulation. Having a patent ductus arteriosus plus or minus that of a patent foramen ovale would be beneficial in maintaining and buying time. This would be because it would allow for high pressure in the transposed pulmonary trunk to mix blood and send it into the aorta through the ductus arteriosus for systemic circulation. Looking at the example on the right, let's think about common ductus arteriosus. This is where there is failure to septate in the outflow tract. This is normally associated with a ventricular septal defect, and therefore there is mixing of blood between the left and the right side of the heart. This mixing of blood will result in cyanosis, as blood is mixed and made its way back to the lungs, but also around the systemic circulation. In this final example, we can see total anomalous pulmonary venous return. Here we can see the oxygenated pulmonary veins empty into the superior vena cava and make their way back through the pulmonary circuit. If the foramen ovale or an ASD and the ductus arteriosus remains patent, this is potentially survivable, as it allows mixing of blood to enter the systemic circulation. So for further treatment, in some cases to buy time until surgery can be performed, we would look at supplemental oxygen. We would also look to add a nasogastric tube for feeding, as it is difficult to suckle whilst breathless, and this would help to limit the effects of failure to thrive and build the mass of the baby until surgery could be performed. We would also look at keeping the baby upright and using diuretics to reduce edema caused by pulmonary hypertension. And as discussed, provide prostaglandins to prevent that ductus arteriosus closing, allowing for the mixing of blood to enter the systemic circulation. Because when all said and done, mixed blood is better than no oxygenated blood entering the systemic circulation. And that brings us to this end of this lecture on the development of the heart and congenital heart defects. You should now be able to describe the migration of the progenitor heart cells from the epiblast to the lateral plate mesoderm. Describe the locations of the primary and secondary heart fields and know which structures arise from these regions. Explain the consequences and disruption of the heart fields, and appreciate that laterality is established early, and explain the result of disruption of the heart laterality pathways. Explain the basic patterning of heart looping, and explain the possible causes of congenital heart disease. You should also be able to classify common and/or serious heart defects as cyanotic or acyanotic, and understand the symptoms and signs that arise from these defects.